A very warm good evening to one and all present here. I am Abhi Chaudhary, working as Assistant Professor at Banarsi Das Chandiwala Institute of Physiotherapy. On behalf of BCIP, I would like to welcome you all to next part of Alumni Talk series. We are here to discuss spine scan. Today we have with us Dr. Tanya Chopra. Thank you, Dr. Tanya, for joining us. Dr. Tanya graduated from BCIP and completed her Masters of Science in Rehabilitation Research Physiotherapy from Dalhousie University. She is currently working as a research assistant in stroke rehabilitation. She works with stroke survivors to deliver evidence-based treatment plans to optimize upper and lower extremity recovery. Now, I request Dr. Tanya to kindly take over the session and enlighten us with spine scan.
Thank you so much, Avi ma'am. Hi everyone, thanks for joining today's session. I'll just share my screen and start. So today's topic is spine scan. Today we'll be going through the following topics, which are active range of motion, passive range, resisted isometric movements, myotome testing, dermatome testing, and reflexes. So the first part is active range of motion. It is the movement of the joint provided entirely by the individual, and it compromises of joint range, control, muscle power, and patient's own willingness to perform the movement. Whereas passive range of motion is the movement applied to the joint solely by another person. In this case, it would be us, the physiotherapist, and it is used to determine the available range of motion and end feel. So on this slide, we can see that in the active range of motion of cervical spine, there is extension, which is movement of the cervical spine backwards, flexion, which is movement of the cervical spine forwards, lateral flexion, which is this movement, and rotation, which is this movement. And in the passive range of motion, the therapist will do the movements which I told you. And for the lumbar spine, it's flexion and extension, side bending to the left and right, and rotation to the left and right. Now we'll discuss resisted isometric movements. So it is a strong static voluntary muscle contraction, which helps us to determine whether the contractile tissue is at fault or not. So we can classify resisted isometric movement in 4 categories, which is strong and pain-free, strong and painful, weak and painful, and weak and pain-free. So what happens is that, say, if we are doing the cervical, in this slide, we'll be doing the resisted isometrics for cervical flexion. So I'll just hold the patient's head and ask him to do an isometric contraction. I'll just tell him that do not let me move you, and I'll apply a pressure backward, and the patient will try to forward flex, which our resistance will not allow him to forward flex. And the same way we will apply pressure here for extension, here for side flexion, and here for rotation. So if we will notice how the contraction is, and we'll ask the patient how he's feeling. So if the patient says that the contraction is strong and pain-free, so this means that there is no lesion in the contractile unit. Contractile unit are the muscles and the tendons which are present in the body. If the patient says that, if the contraction is strong, but the patient complains of pain, it means that there is a local lesion in the muscle or tendon, which can be a 1st or 2nd degree strain. And if the patient, the patient says the contraction is weak and painful, it means that it could be a fracture. There is a possibility of a fracture. And if the contraction is weak and pain-free, it can be that there is a rupture of a muscle or tendon, which is a third degree. So in third degree muscle rupture, all the nerve endings and muscle tendons are ruptured. So the patient does not feel anything. That's why in this, the patient will feel that the contraction is pain-free. For flexion and extension for the lumbar spine, we'll keep the hand in this way. As the patient will bend forward, the therapist will resist with this hand. When the patient is bending backwards, the therapist will resist with the hand on the posterior side. And for side flexion, the therapist will resist, as shown in the picture, towards the arm. And when there is cervical, for rotation towards the right or left, the therapist will resist in this movement. So it is very simple. The movement which we have to do, we have to resist in the opposite direction. Now we move to myotome testing. As you all must be knowing, myotome is a group of muscles supplied by a single nerve root. So a single nerve root supplies a group of muscle, but for the purpose of testing, there is a select group of muscles which are selected, and we test those only. So in this, first of all, we'll make sure that the patient is in a comfortable position. So in case of cervical spine, we'll make sure that the person is sitting comfortably, and we'll explain him like what are we doing so that he doesn't get nervous. And we will be explaining all this to him in layman terms. And for C1 and C2, we will be testing resisted cervical flexion. So it is the same. But we have to hold till 5 in this. So we will say like, move your head forward, and we'll count till 5. So it will be 1, 2, 3, 4, 5, and then we will ask the patient to relax. And in this, how we document is this: if the patient has pain or fatigable weakness. So in myotome testing, we are looking for fatigable muscle weakness. And for the C3 nerve root, it is tested with cervical side flexion, which is this movement. We'll hold for 5. And then C4 is resisted shoulder elevation, which is this movement. C5 is resisted shoulder abduction, which is this movement. So the therapist will resist here and look for fatigable weakness. C6 is tested with resisted elbow flexion or wrist extension. So you can opt with any of the movement, either elbow flexion or wrist extension. C7 is tested with resisted elbow extension, which is this movement, or wrist flexion. C8 is finger flexion, and T1 is tested with thumb abduction or finger abduction. For a lumbar scan, we will ensure that the patient is either in the high sitting position or the patient is in supine position. And we'll begin with L1, L2. So it is tested with resisted hip flexion. And for L3, it is tested with resisted knee extension. For L4, it is tested with resisted ankle dorsiflexion. For L5, it is tested with resisted great toe extension. For S1, it is tested with resisted plantar flexion or hip extension, so we can opt for any one. And S2 is tested with resisted hip flexion. And this completes the myotome testing. And in front of, and whatever myotome shows fatigable weakness, we can say that that nerve root is affected. But to make sure, we would be doing the dermatome testing. So all of you must have always seen this chart, which is very difficult to remember. But in terms of dermatome testing, we follow a procedure which I'll highlight in the next slide. So ensure that the patient is comfortable. Demonstrate normal sensation using flat, broad strokes over an unaffected area. So say if the patient complains of pain on the right upper extremity. So we can test the normal sensation either on the left upper extremity or in the lower legs, as they do not have any complaint in those regions. So we have to use strokes like this. I'll just show you on my hand. So it has to be flat, broad strokes. So we'll explain him the testing procedure, that what we will be doing and what we expect out of him. So first of all, we will be telling him to open his eyes, and we will be doing it on the unaffected side. So just a flat, broad stroke. And then we'll have the patient to close his eyes, and we will test on both the sides simultaneously. And we have to ask the patient if he feels that they feel if it is the same or they feel it is different. So if the patient tells that it is different, that means that dermatome is affected. So then we'll ask him how different does he feel. Does he feel less on that side, on the affected side, or does he feel more sensation on the affected side? So I would like to highlight a few points as the dermatome chart is very vast, but there are a few set points on which we can give the broad strokes to the patient, and because they can be very daunting to remember sometimes. So I'll just tell you a few points which are easy to remember. So we can test for C2 here. As you can see below the ear, we can test for C4 here, which is on the initial portion of the neck at the side, on the lateral side. Then we can test for C4 above the clavicle, which is this portion. We can test for C5 over the deltoid region, which is this region, the shoulder blade region. And then what we can do it for C6, we can test on the lateral aspect here. And for C6, we will go to the thumb. We'll touch on the thumb. For C7, we'll touch on the middle finger. Here. And then for C8, we'll touch on the index finger. And then for T1, we will touch on the medial aspect. So you can remember like this, that we start from the front, then we go laterally, and then on lateral there is 1 point, and then we'll go on the thumb, and then the index finger, then the middle finger. So from laterally, we are traveling medially, as C8 is the little finger, and then T1 will go medially upwards, so it would be T1. And for the lower extremity, it's comparatively simple to remember. So L1 would be near the groin area. L2 would be just below that, so you can touch on any point. L3, so L1, L2, L3, and L4 are on the thigh only, but at different regions. L5 you can test on the big toe, as L5 does big toe extension. And for S1 and S2, for S1, it would be you can test the medial hamstrings, and for S2, you can test the lateral hamstrings. Now we will go towards reflex testing. So first of all, make sure that you that you ensure patient comfort and tell him to relax by taking a deep breath and closing the eyes, as it becomes very difficult. If the patient is aware of what is happening, it would be very difficult to elicit the reflex. And these are the deep tendon reflexes which we usually test while we are looking for integrity of the nerve roots. So the first is biceps. We tell the patient, we'll flex the patient's arm, and we will tap on the biceps tendon, which is on the radial tuberosity. And then for brachioradialis, we'll tap on the radial styloid process, which is here. And then for Achilles tendon, make sure that you can do it in either supine or high sitting. And and make sure that the foot is slightly dorsiflex, so that when you tap the tendon, you look for plantar flexion. So in biceps, you will see elbow flexion. In brachioradialis, you will see elbow flexion in the mid-prone position, and in the Achilles tendon, you will see ankle plantar flexion. For triceps, you will tap above the olecranon process of the ulna, and then we will look for elbow extension. And in the patellar jerk, we tap at the patellar tendon and we look for knee extension. So it is so the testing is very easy, but it is very difficult to remember the nerve root, and we have to remember the nerve root in order to determine which reflex we will check. So you can remember this way, like you can count from 1 to 7. So if we start from the ankle jerk, that's 1 and 2, and we know that ankle plantar flexors are supplied by sacral nerve root, so we can remember sacral nerve root that way. And 1 and 2 is a nerve root which will be affected. And then as we move up, that there would be knee jerk, and that is L. Move up, it is biceps and radialis, which would be C5 and C6, and triceps, which would be C6 and C7. So 1, 2, 3, 4, 5, 6, and 6, 7. I hope this will help you in remembering the nerve root. And then we move forward towards the red flag. So whenever a patient comes to you with either neck pain, so make sure that before initiating any treatment, you rule out the red flags. So you can remember it this way, that there are 5 Ds and 3 Ns. So 5 Ds are diplopia, dizziness, dysphagia, dysarthria, drop attacks, nystagmus, nausea, and perioral numbness are the 3 Ns. The last ones are the 3 Ns. So like we have to ask the patient, like we cannot ask the patient that aapko diplopia hai, we cannot say like this. So we have to explain him in layman terms that do you feel double vision? क्या आपको ऐसा लगता है कि आपको चीजें दो दिख रही हैं? Or dizziness, you can ask him that do you feel that आपको ऐसा लगता है कि आपको चक्कर आ रहे हैं कभी? And third, dysphagia, you can say that आपको खाना अंदर निकलने में कोई दिक्कत है. Dysphagia is problem in swallowing, and dysarthria means problem in speaking. And drop attacks means that the patient will feel a blackout and then he'll fall. And nystagmus means that he has a problem fixating his eye on one object, and he moves his eye medially and laterally or up and down. And nausea is that does the patient feel like he wants to vomit. And perioral numbness is numbness around the oral cavity. So you always remember that you have to ask these things to the patient in the layman term. And it will help you to remember the red flags using that mnemonic which I have written. And for lumbar spine, always ensure to ask the patient before you treat him, if the patient has come with a complaint of back pain, that do you have bilateral leg pain or numbness, or do you have any bowel or bladder disorder? That means that is it difficult for you to control your urine, or you're not able to go to the washroom on time? And same, you can ask for the bowels. And for a saddle anesthesia, it would be very difficult to explain him what is the saddle area. So you can just ask him that, do you feel any loss of sensation in the area which touches the bicycle seat? So in this way, it would be easy for the patient to understand if you ask him about the saddle anesthesia. So now we will discuss a case study in which it will help us to determine how we can assess that if the patient is having a nerve root problem, or if the patient is having a peripheral joint problem, which can be any joint like shoulder, elbow, hand, hip, knee, or ankle. So in this, the patient has come to you with complaint of pain in the deltoid region, and you have to assess whether the pain is coming from the neck region, like it can be a radiating pain, or it is a problem of the shoulder itself. So like there's a problem in one of the muscles or one of the ligaments of the shoulder. So first of all, we will start with the subjective history. Like, as you all know, we take a history of the patient. We'll ask him that what happened to you, and like when did the pain start, and we will take a detailed pain history, like what was the onset of pain, what is the location of the pain, and what kind of pain are you having? Is it a dull aching pain, or is it a sharp shooting pain? So if the patient says that it is a sharp shooting pain, it directs us towards cervical spine involvement. And if the patient says that it is a constant dull aching pain, so we can start moving towards the peripheral joint assessment. But we'll ask about what are the factors which aggravates the pain, what are the factors which relieves the pain. So we will take a detailed pain history, and then we will observe the area. Like we will observe where he's having pain, like is there any swelling, or is there any redness, or do we see any muscle wasting in that area? And then we will palpate the painful area. So we will look for if there are any tender structures. So first of all, we will go towards the cervical spine. And in palpation, we'll also look for temperature, that if there is any temperature variation compared to the left and right side, the affected and the unaffected side. And then, as I told you before, we will start with the active range of motion of the spine. So in this, we will ask him to do the flexion extension, side flexion and lateral rotation. And in passive range of motion, we will assist for the same. So always make sure that you'll ask the patient that if it is painful or if it is pain-free, and you have to note down how much range of motion he's having. And in the resisted isometric of the cervical spine, we will do the same, which I told you in the previous slides. We will test for strength, and then we will note down each movement, if it is strong and pain-free, strong and painful, or weak and painful, or weak and pain-free. And then we will do this special test for the cervical spine. So first of all, you know that there is a cervical compression test. So in this, what happens is, this is to determine the integrity of the cervical nerve roots at the level of your spine. So you'll take the patient in a sitting position, and then you will apply pressure. And so when you apply pressure downwards, the cervical nerve roots are compressed. So if there is a problem of the nerve root, the patient will have the pain which he used to have. So while you're doing the special test, always make sure to ask the patient that where he is feeling pain. So as if like, I have no problem and I compress and I may also feel a pain. So the patient can say that way, oh yes, it's very painful, it's very painful. So you have to make sure that you ask the patient that, is it the same pain that you feel every day? Is it the same pain with which you have come to me today? And like, has the pain with this, that pain has increased? And to confirm the diagnosis, if the patient says that yes, it is the same pain and the pain has increased, so then we will perform the cervical distraction test. In this, we distract the cervical spine, so the nerve root, the pressure on the nerve roots is released. So if these are the spine, and then we distract the spine, so the pressure on the nerve root will be released. So, and the patient will complain that it is less painful, like the pain which he was having, it is relieved now. So in that case, the test will be positive. And if we determine that yes, the cervical compression test is positive, so then the neurodynamic test, which is the cervical compression and distraction test, if they are positive, then we will move on to the myotome assessment. And in myotome assessment, whichever muscle has whichever muscle has weakness, then we will note down that that nerve root level. Say like the patient has come with pain in the deltoid region, which is this. So it can be possible that the shoulder abductors are affected, as the supraspinatus inserts here at the upper aspect of the humerus. So we will make sure, so imagine that in this case the C5 myotome is weak. So to confirm our diagnosis once again, like we will test for the dermatomes, and then we test for all the dermatomes by closing the eyes, C1, C2, C3, C4, C5. And it is very probable that if the patient is having pain in the deltoid region, the patient will have decreased sensation in the dermatome of the C5, which is this area. And then as the patient is having, like, as the patient, that dermatome is affected, so we will do the reflex assessment, like whichever nerve root is affected. So if C4, C5 or C5 is affected, we will look for the biceps reflex and the brachioradialis reflex, and then we can note that if it can be elicited or not. And then what happens is that if the neurodynamic testing came out to be negative, then what we will do is that we will start with the shoulder joint assessment, as we know that there was no problem in the cervical spine. So for the shoulder joint assessment, you will ask the patient to do active range of motion of the shoulder, which is shoulder flexion, shoulder extension backwards, and then abduction towards the side. Then we will ask him to do internal rotation and external rotation. And then there's one more movement, which is horizontal adduction and abduction. So we'll ask the patient to do all that. So if we suspect that there is an injury in there is pain over the deltoid region here, so there might be an shoulder impingement, or there can be strain of the supraspinatus tendon or overuse of the supraspinatus tendon. So if that is the case, then patient will be having pain in shoulder abduction. So let's assume that in this case the patient is having pain in the shoulder abduction. So we'll do the passive range of motion again for all the movements, and then we'll see that when it is painful, so the patient will most probably be having pain in passive range of motion again, as of abduction, as we are assuming that in this case there is a supraspinatus strain or there is an impingement. And then we will test for resisted isometric movement, and in this we will look for all the resisted isometric movements of the shoulder. So I'll show you how we can do. So always remember, in case of resisted isometrics, the muscle and the joint should be in a relaxed position. So for shoulder, we can keep it in this position, and for flexion, we can test this way. We can ask the patient to move forward, and then we'll look what is the strength of the contraction, and we'll ask him if it is painful. And then for extension, we will keep it back and move and ask the patient to move backwards. For abduction, we will keep it here, and then we'll ask the patient to move towards the side. And for internal rotation, we will keep it this way, and for external rotation, we will keep it this way and perform the resisted isometric movements. And in horizontal adduction, you can do this for abduction and you can do this for adduction. So as the patient was having pain in abduction, so most probably the resisted isometric movement of abduction, shoulder abduction will be painful, and it will be, it can be strong or it can be weak depending on what kind of strain is it, or is it an impingement or not. So if we say that that it is strong and painful, so we can come to a conclusion that it is a first or second degree muscle sprain. But to confirm what it is, then we will perform the special test of the shoulder. So supraspinatus tendon can be tested by the empty can test. And in this, we will keep the patients, like this is a passive test. So we will place the patient's hand in 90-degree abduction and in the scapular plane, which is this plane, and we will ask the patient to do thumb down, which is this position. And then we will apply a downward force and we'll ask the patient to resist, like the patient will move upwards, and which is the action of the muscle doing shoulder abduction. So if the patients complain of pain in this, then we can be sure that it is a problem of the supraspinatus muscle, and it is either an overuse or a muscle strain. And then but you, like, what happens with special test is that you always have to do 1 or 2 special tests to rule in or rule out what is the condition. So if there is pain here, you can think of supraspinatus strain, or you can either think of impingement, because when the patient will be going overhead, so what happens is impingement is that the muscle tendons, the muscles which are present below the coracoacromial arc, which is here, there is, as we move up, there is impingement in those structures as the space is decreased between, like say this is the coracoacromial arc and this is our muscles of the shoulder. So as the space is decreased, whenever you'll move up, there will be pain. So there can be, as the patient was having pain in shoulder abduction, there could be a possibility that there is an impingement. So we will then do the test for impingement. So it depends, like if there is subscapularis strain, if there is supraspinatus tendon strain, then we will we'll do the empty can test, and always make sure that to rule out, you perform the tests for the shoulder impingement. So we will perform the NEER'S impingement test. In this, what we will do is, it is a passive test. So the therapist will move the patient's hand in forward flexion and medial rotation. So always remember that whatever test we are looking for, we have to do the same movement. So this was that was a supraspinatus test. So in this, we'll do the movement of abduction only to see whether there is pain or not. In the NEER'S impingement, if we move our arm up and we medially rotate it, so what happens is that this makes the tendons compress between the coracoacromial arc. So in this way, we will look for if there is impingement or not. So then the patient will move it forward. And then if there is pain, the test is positive for NEER'S impingement. And similarly, you will ask the patient in this also that where are you having pain? It can be that the patient has decreased mobility of the shoulder muscles. He is like 50 plus, he's diabetic, so he might be developing frozen shoulder, or he has decreased mobility and flexibility of the shoulder muscles. So it can be a stretch pain also. So you have to make sure that you ask the patient that is it the same pain that you experience or with which you have come to me for a complaint. And the test to confirm the impingement we can do is the HAWKIN'S test. And it is based on the same concept, like we will do forward flexion and medial rotation. So in that we were doing in this way medial rotation, in this medial rotation we will be doing this way, and then we will resist this movement. So the patient will try to move his hand this way, and then but we will provide resistance, and then the patient will feel pain here as we're moving in the flexion and medial rotation direction, which is impinging the structures. So the patient will be having pain upon this area. So that is so this is the way how you can differentiate if it is a spine problem or if it is a problem of the peripheral nerve root. So that is it from cervical spine. Thank you so much, and always remember to wash your hands. And if you have any questions, please let me know. Sir, I cannot hear you.
तुम मेरे फ्रेंड नहीं हो ना।
Hello.
Hello.
Hello, Dr. Tanya. Am I audible?
Yes, yes, ma'am.
Thank you, Dr. Tanya. That was an exemplary explanation. Now I would like to ask some questions related to your presentation. So
Yes.
my first question is, what is the difference between RIMS and MMT?
In RIMS, what happens is that we are looking for the only like how the contraction is. It is an isometric contraction, but in manual muscle testing, we are looking that if the muscle can move against gravity or it can move in the gravity eliminated plane and how much resistance it can take, minimal resistance, moderate resistance, or maximum resistance.
Okay, thank you, Dr. Tanya. My next question is, when to perform active and passive range of motion in nerve root and peripheral joint involvement?
Okay, so what happens is that in active range of motion, if the patient we perform the active range of motion and the patient does not complain of any pain in that, but there can be a possibility that a ligament is affected, which is a non-contractile structure. So when we passively move the joint, in case of a ligament injury, then there can be a pain. There can be pain.
Okay, thank you so much. The last question is, what are the functional tests we can do in peripheral joint assessment in upper and lower extremity?
We usually do functional tests, like if we have to differentiate between cervical spine and the peripheral joint involvement. So before proceeding on to the myotome dermatome testing, we can do aptly scratch test, that we will move our hand on the opposite scapula and scratch our back. So in this, what happens is that it is a functional test for the upper extremity. So there is movement of the shoulder, elbow, and wrist both. So in this way, we can see that which joint is problematic, and then we can move on to the assessment of that joint.
Okay, thank you. Thank you, Dr. Tanya, for clarifying our doubts. Now, I would like to ask one personal question. How did the learning and practical skills you acquired in BCIP helped you in your career?
So first of all, I'm very thankful to all the teachers at BCIP and who have always helped me. The education and the concepts which I learned at BCIP and the practical skills which I learned have been really helpful, and the strong concepts have helped me a lot. With the concepts which I acquired have helped me to become a competent physiotherapist.
Okay, thank you. It was such a pleasure having you as an esteemed resource person here. On behalf of BCIP, I would like to thank you for enlightening us. Now I have a small request for our audience. Kindly subscribe our YouTube channel for informative lectures, study material, and many more things. Our next webinar is on 11th of July, and the topic would be Journey to become a licensed physical therapist in United States. Thank you all for joining us. I hope all of you have enjoyed today's session. Thank you, Dr. Tanya.
Thank you, ma'am.
Thank you so much.
Thank you so much.
Thank you, Savita.
Thank you. Thank you.